Thank you so much. Once again, it's a pleasure to be here. I'm sure, especially in Asia, all of us have watched either Chinese movie or Indian movies where the parents would get so mad with the kids, and then especially the mom would just grasp her heart and just sort of collapse. And I'm sure when we were young, our parents have always told us, if you don't listen to me, I'll die of a heart attack, right? Boy, that's, it's repeated in the movie now. The question is that a real syndrome? So I'm going to just share with you this morning that indeed there is this syndrome called the broken heart syndrome. These are my disclosures. I've got nothing related to this presentation. So let's start by a case presentation. We have a 75-year-old female that came in to the emergency room with a 24-hour history of chest pain and short of breath. Significant in her history is that her 45-year-old daughter had just been diagnosed with stage 4 breast CA. Exam was really unremarkable. EKG showed some T-wave inversions. Troponin was positive. So she was treated like having a non-ST elevation STEMI and had an urgent coronary angiogram done. However, the angiogram was negative for any significant blockages. So she was brought back to the CCU, and we were asked to do an echocardiogram. Let me orientate you. This is sort of the modified parasternal, and as you can see, the apical and mid walls here are not contracting, and you have maybe hypercontraction of the basal walls. This is the Mayo format of the apical four-chamber. The left ventricle is on the left, and the right ventricle is on the right. As you can see, the right ventricle is working well. Once again, from mid to apex here, it's really not contracting, and the base is doing okay. This is the apical five-chamber once again. Sort of the base is contracting well, apex is not. And this is just a short axis of the apex, and you can see that there's certainly regional wall motion abnormalities. So, the patient was treated with the traditional beta blockade, ACE inhibition. She was stabilized, she was sent home, and in about 4 weeks she returned for a follow-up echocardiogram. As you can see, the apex is contracting well here. All the walls are contracting well with a normal ejection fraction. So within a 4-week period, her function has really returned to normal. See how well this apex is contracting right now. Second case presentation, I was on call and I was called in to do an echocardiogram at 5 a.m. on a potential heart donor. So it's a young gentleman, unfortunate gentleman, that is declared brain dead due to subarachnoid hemorrhage. So I did the echo and declared that his heart function was completely normal. Then the transplant took place, and at 7 p.m. I was called to the surgical ICU again, and they said, boy, the patient that received the heart is not doing well. Can you do an echocardiogram? So I was on my drive-in, I was of course worried, did I miss anything on the echocardiogram that I did in the morning? And once again, it shows that there is sort of mid to apical hypokinesis and hyperkinesis, so contracting well at the base. And this is just a two-chamber view, and you can see it contracts well. And we can do speckle tracking longitudinal strain. And if you just look at these images, the sort of light colors are the regions that don't contract well, and the red are the regions that contract well. So the base of the heart is contracting well, the mid and the apex is not contracting well. Thankfully, we realized that, the patient most probably had stress-induced cardiomyopathy. We treated patient conservatively with beta blockade, ACE inhibition, and after 4 weeks, all the function recovered in this patient as well. So there is this phenomenon called stress-induced cardiomyopathy. It's also called apical ballooning syndrome, Tagore-Subel cardiomyopathy, broken heart syndrome, And this is actually characterized by a transient regional dysfunction of the heart. So as you can see, they have regional wall motion abnormalities, EF is reduced, and yet when you do a coronary angiogram, you do not see significant obstructive coronary angiogram to explain the hypokinesis, actually. And of course, in some older patients, they may have certain blockages in the coronary arteries, but the area of or hypokinesis extends beyond the territory that's perfused by a single epicardial coronary artery. So this was first described in 1990 by the Japanese group, and hence the name of Takotsuku's cardiomyopathy. Since then, it has been recognized and reported worldwide. The prevalence is about 1 to 2%. And the International Takotsubo Registry, which we are part of as well, has a collection of 1,700 patients. And about 90% of these patients are women, and they are usually postmenopausal with a mean age of 64. So we can classify them into typical type or atypical. And another name for typical could be the apical one. And the typical ones are what I show you, and this occurs in 80% of the patient, where you have hypokinesis of the mid or the apex sparing the base. So that's the most common presentation. You can have atypical ones. The mid-ventricular one is really quite rare. I've only seen maybe about 2 cases where only the mid-ventricle is hypokinetic, the apex and the base is preserved. The basal one is even rarer, and you get some focal and some global. So just take-home message is about 80% is the typical and 20% is atypical. Now, this recent study sort of looked at patients with atypical versus typical. Once again, they show 81% is typical, about 18% atypical. Now, in the atypical one, they seem to be younger of age, more frequent ST depressions, higher prevalence of neurological disease, less pronounced LVEF reduction, and lower BNP. The important thing to know is that the outcomes is comparable. So regardless of whether they're typical or atypical, the outcomes is comparable. Now, what's the exact mechanism? We don't know. There's been speculations. There have been small physiological studies. But I think one could attribute that to catecholamine excess because of the stress, microvascular dysfunction. It could be coronary artery spasm, or it could be dynamic outflow tract obstruction. But the important thing to note is that as high as 60% of these patients have a history of psychiatric issues such as anxiety and seizure, compared to about 30% in patients with just acute coronary artery syndrome. So once again, this is the registry again, and a high percentage of patients, up to 50%, have some sort of trigger, either physical trigger or emotional trigger. And the most common presentation is this chest pain, dyspnea, and syncope. One important we think we learned from the registry is that most of the patients do well, but about 10% of them do develop a cardiogenic shock. And the long-term outcomes, even though with recovery of LV function, they still have about 10% chance of per year of cardiovascular events, and the rate of death is about 5% per patient year. So this is a recent study where they compared patients with stress-induced cardiomyopathy versus patients with coronary artery disease versus control. The outcome is about the same between those with coronary artery disease and with stress-induced cardiomyopathy, and these are significantly worse than patients that did not have either. And they also found that patients had more COPD, and the use of beta agonists predisposes them to stress-induced cardiomyopathy. In terms of diagnosis, Abi Prasad from our institution have been working with the group, and they've come up with the Mayo Clinic diagnostic criteria, which is widely used. All 4 are required. So you have transient LV dysfunction, absence of obstructive coronary artery disease, new EKG changes, and you got to rule out pheochromocytoma or myocarditis. In terms of diagnosis, these patients basically if you suspect acute coronary syndrome, even though they may give a history of physical stress or whatever, mental stress, you still have to treat them for acute coronary syndrome. So do not delay what you normally do for acute coronary syndrome just because you think, boy, it could be stress-induced. You bring them to the cath lab if you need to, or start whatever therapy that you would. So that the take-home message is do not delay revascularization. After that, the one thing you need to rule out if patients develop cardiogenic shock is to make sure that they don't have LVOT obstruction. As you can see, the mitral valve is being sucked into the LVOT, and these patients, because the basal segments is hyperkinetic, they can develop LVOT obstruction. And if you see that, you should consider using epinephrine or even beta blockade instead of an inotrope. There's really no randomized data to guide us into how to treat these patients. Like I say, you need to sort of rule out acute coronary syndrome. Then if patients and rule out any apical thrombus as well, because as you can see, the apex is hypokinetic. So one would anticoagulate if they do have a thrombus. And with patients with severe LV dysfunction with EF less than 30%, there's a consensus that you might consider starting on anticoagulation if the risk for bleeding is low. Overall, the in-hospital mortality is about 4% in these patients. So that's all I have. And we can take any questions later or now.
Sure.
Yep, thanks.